one of the things that I like to start with is a picture of the team in Kenya. Largely due to COVID, I'm no longer able to be based full-time in Kenya, but my team is still working there and doing great things. So this is the team that we work with in Kenya. I was actually hoping that I could make it in person for this Georgetown lecture. Unfortunately or fortunately, I'm in the other Georgetown right now. I'm in Guyana, helping the Ministry of Health develop a population health effort as well. So in the future, I'm hoping I can do one of these in person, as I've spent a good bit of time in Washington, D.C. But for today, my hope is to talk about global to local, also known as reciprocal innovation, and how equity applies to a lot of the service delivery that we do, both locally in the US and abroad in some of the other places I work. So you can see my objectives. I'm going to talk about the intersection of equity and clinical care, analyze social determinants of health, and then talk about how we can apply some of these lessons to the US. But before I get too far into that, I'm sure many of you, I see more than 30 participants, are probably so tired of doing Zoom lectures. And I know I was, because for a year and a half as a lecturer at Purdue, I did tons of Zoom lectures, and it got pretty boring for the students and sometimes boring for the lecturers. So one of the things that I tried to do was I tried to learn magic and see how I could do magic over Zoom. So if you'll humor me, my hope is that you can actually participate with me in trying to see if my magic skills are up to par. So I'm hoping everybody can participate with me. Just choose a number from 1 to 10 and keep it to yourself. Don't share with anybody else, just keep it to yourself and keep it in your brain. All right, now whatever number you chose, I want you to multiply that number by 9. So if you pick 2, that would be 18, and so on and so forth. So you can do the math and keep that number to yourself once again. All right, now whatever that number that resulted, I want you to add the 2 digits of the number together. So if your resulting number was 25, your end number would be 7. Everybody still with me? All right, so whatever number you got there, I want you to subtract 5 from the number you got as a result in the last step. Still with me? Liz, I can see your video, so you can always give me a head nod. Cool. All right. All right. So now one of the last steps is I want you to convert that number into a letter in the alphabet as seen in the table. So if your number was 5, it would be E. If it was 8, it would be H. Whatever number you got, I want you to convert that to a letter. And then the next couple of steps, I'm hoping you can do kind of fast. All right. So I want you to think of a country that begins with the letter you just selected. So I'll give you 5 seconds, do that as quickly as you can. All right. All right, now I want you to think of an animal that starts with the last letter of the country you selected. All right, next. And now I want you to name a fruit that starts with the last letter of the animal you just selected. So once again, keep all these answers to yourself. I'm hopefully going to be able to read your mind. So if you can give me 10 seconds to try to think of what answers you came up with, I'm going to try to read your mind. All right. All right, so how many of you picked Denmark, kangaroos, and oranges? If you could give me a reaction of a thumbs up in the as a reaction in your Zoom, I would appreciate it if I got it right. Thumbs down if I got it wrong. I'm seeing one thumbs down, 1 thumbs up. Seeing a couple of thumbs ups, couple of thumbs downs, mostly thumbs ups. Okay, so I'm seeing about 70% thumbs up and 30% thumbs down. Now, anybody want to take a second and explain how I did this or what I did? So the first part of this is pretty straightforward. It's a fairly straightforward math thing that your result is going to always end up with a D. Your math result is always going to end up with a 4, and you're going to give me a D. Now, what's interesting is when I do this in Indiana, which is where I'm now based, I get about 95% of people to give me these 3 responses. And what's really interesting is that most people pick Denmark. Anybody, Liz, I saw that I got a thumbs down from you. Which country did you pick?
I was thinking the continent of Africa, so Djibouti.
And that's exactly the point. So I did this This is a global health track. And this is what happens when I do this lecture with people who have more global health interests, is that I get different countries. Whereas when I do it with my pharmacy class in Indiana of over 160 people, I get about 95% responses that are these three things. And my whole reason for this is not just simply magic, it's to talk about some of the implicit biases that we have in society. And so, even within doing this, I'm guessing there is probably about 70% that had the same answers, even though there's probably about 10 to 15 different countries that start with the letter D. By and large, most people in America will pick Denmark. And so that kind of implicit bias, it's useful for a magic trick like this and doesn't have consequences, but these other implicit biases that we have often have consequences. And so the thing that I try to highlight, especially now that I'm spending more time in Indiana, where there is a good bit of structural racism and there is a lot of implicit bias, is that implicit bias does not equal racism. These hidden and implicit biases are with everybody. To be honest, somebody like me who's lived in Kenya from 2007 to 2019, Denmark was the first country I picked as well. It doesn't mean I'm a racist. It just means that I have these hidden biases. And the big point of even going through this exercise is that if we can actually highlight some of our implicit biases, we can check them. And as you can see there over to the left, I mentioned the two conditions for implicit bias to exist in a society. And it's basically that you have a brain and you live in a society. And once again, that does not equal racism. What happens is if you don't check some of these biases and you're not aware of them, then that leads to structural racism, and then you start to get consequences. And so that's kind of the starting point for what I want to talk about to highlight some of the things that we have in our society. So I want to, before I go into too far detail, I wanted to highlight another study that was done in rural Wisconsin, which really is telling to me. And so what they wanted to do in this study was figure out the contribution of the social determinants of health and other aspects of health on health outcomes. So they studied this fairly large rural population in Wisconsin and looked at what was really driving the health outcomes. And so they defined health outcomes as being 50% defined as the length of life and 50% as the quality of life. So in the chat, I'm hoping people can tell me what percentage of health outcomes are related to clinical care. And so if you can basically give me a chat response of what percent you think of health outcomes are due directly to clinical care. So that's the care that patients receive in clinics, hospitals, from their providers. What percentage of care of health outcomes do you think are driven by the clinical care you receive? So if you can put some messages in the chat, I'm looking at the chat right now. I see Sean with a starting number. I see 9%, 20%, 30%, 33%. Good, 25%. Good, this is all very helpful. And so in this Wisconsin study, what they actually found, which was the number that a lot of you quoted, was that it was only 20%. And so, the people who at 9 and 10%, you're actually right for a good number of other settings. In the UK, they estimate that it's about 9 to 10%. In Canada, they estimate that clinical care is only responsible for about 9 to 10% there as well. But in the US rural section, this clinical care is only 20%. Now the reason I highlight this is because if you look at the way the US funds services designed to help people improve their health, by and large, we concentrate so much of our resources on clinical care, despite the fact that it's only 20% of the determining factors for the health outcomes. It's all these other factors that make a huge difference. So if you look at health behaviors, that's 30%. If you look at the physical environment, that's 10%. And what we're finding in more recent literature is that this physical environment component is getting larger, especially as climate change starts to take its toll on societies around the US and around the world for that matter. And then lastly, the biggest one is social and economic factors. And so 40% of health outcomes are determined by these social and economic factors. And so this is really just important for us to note that if we as providers are comfortable with only responding to 20% of the things that drive health outcomes, think about how limited you are in actually improving the health of your patients. And so what I try to train students, what I try to train a lot of our fellows and residents is that it's all these other factors that we need to start incorporating into healthcare systems. And if we don't do that, we're basically saying that we're complacent with only modifying 20% of a lot of these things that are changeable for our patients. And so that to me is the next big transition for healthcare and healthcare systems, is that we're going to start incorporating social factors and social and economic factors more holistically into our healthcare systems. So for me, I know that those numbers are a little abstract, and I try to capture visually how I see it. And so after spending so much time in Kenya, this is basically how I think of it. So my hope is that people, when they're seeing patients, will start to think of it in this fashion. And the way that I think of it is that each of these different social determinants of health are different layers of protection against health injuries. So you can see in the left up here, the top left, this is the baseline. Let's just assume this is a middle-class population. They have these varying layers of protection of different radiuses and sizes. And you can see that these breakdowns, the percentages still hold true. Now, if you look at the low-income population, you can see all of their layers are thinner. And what this means to me is that these people are going to be at higher risk for health injury because they don't have as much insulation. Now, the other thing I hope that you leave this visual with is the appreciation of the notion that you could improve that clinical care dynamic to be as maximal as possible. You could maximize that 20%. All those other layers are still going to be there and be very thin. And you can only protect the patient from health injuries so much. And I'm sure for many of you who work in low-income clinics or federally qualified health centers, you see this all the time, where even after you optimize, whether it's diabetes or hypertension, there's still all these other factors that are leading to health consequences for them. And so once again, this is important for us to start integrating the health system. Now, lastly, if you look at high-income populations, you can see all the layers are larger. And the example I would challenge all of you to just think about is, imagine a low-income population that you're serving dealing with breast cancer or any type of cancer for that matter, and the challenges that they'll face across this whole spectrum versus what a middle-income or a high-income person might face. You know, that low-income person is going to have an hourly job. They're not going to have insurance benefits that are going to cover, and every time they miss work, they're going to lose money. Their diet's going to change. All of these things are going to further complicate the situation. And so I hope you can kind of see visually how these social determinants of health really impact health in a way that is really larger than the clinical care aspects that we tend to concentrate disproportionately the amount of time and money we spend on that. So once again, these characteristics all hold true at the population level as well. And so if you really want to improve health at a population level, there's no choice but to integrate a lot of these things into your care. And now going back to what I was talking about with implicit bias and a lot of these social determinants of health, I wanted to give you background context before I kind of showed you the consequences of these issues. And so when you think about implicit bias, you think about social determinants of health, these two maps of Indianapolis, where I live, basically highlight it for you. And so what I really want you to see here is, if you look at the map on the left, this is basically showing the life expectancy in different regions of Indianapolis. And I'm sure you guys have all seen the maps from Washington, D.C., where they show you just along the subway line, the disparity in life expectancy just across the red line that I'm sure, and the green line that many of you probably take. Whereas in Indianapolis, the similar trends hold true. So if you look in the downtown area, there's a life expectancy of about 69 years. In these upper areas, in the suburban parts that are more affluent, there's a life expectancy of 83 years. Now, what I counter that, what I'm putting on the other side to juxtapose that graph is a map of all the redlined areas of Indianapolis. And for those of you who aren't familiar with redline, this was the practice of basically demarcating zones where people got unfavorable mortgage rates, and the housing that was there was considered to be less favorable, and everything was devalued. And this is predominantly due to a lot of the implicit biases that mortgage agents and banks had in Indianapolis, where they basically downvalued and degraded the value of houses in those areas. And so you can see here, if you look at the two maps, basically the areas with lower life expectancies are these redlined areas. The areas with the higher life expectancies are the green areas, are the areas that were demonstrated to be favorable loan areas and places to live. And so those consequences of the implicit biases, which led to structural racism, hold true in the clinical outcomes that we see here. So these health outcomes that we all I would agree, I'm hoping we agree, are kind of the goals of our practice and our efforts. You can see how these longer term issues that we've had in our societies in the US really start to impact the life expectancy and a lot of these issues that we talked about. So I wanted to even just go a step further and talk about equity versus equality. I'm sure this audience is quite familiar with this, but unfortunately, a lot of times in Indiana, especially with a lot of the misinformation that Republicans were spreading about this whole notion of equality versus equity, there's a lot of confusion over this topic. So this is my way of illustrating this whole notion. And so equality is basically this approach where you treat everybody the same regardless of their circumstances. And in this situation, you can basically see that when you use this equality approach and have bolted in chairs at this table, you can see that the toddler can't really sit there comfortably. They're going to keep falling off the chair. And the person in the wheelchair, they basically don't have a seat at the table. Whereas an approach that's focused on equity tries to basically accommodate the circumstances of the individuals and incorporate a response that takes those into consideration. So now for this equity picture, you can see the toddler, basically we might have to spend a little money and put in the ability to put a toddler chair in there. And for the person in a wheelchair, instead of spending the money on a bolted in chair, by leaving an open space, you actually would probably save a little bit of money. And now the person in a wheelchair has a seat at the table. Both figuratively and literally is kind of the message I'm trying to convey. So if there was any confusion about this, I'm hoping this kind of shows the difference and what we're going for. And these things have direct applications to health. And so once again, historically, the US has applied an equality model to healthcare. And what I mean by this is that we often promote this notion, and I'm not suggesting that any of you do, but publicly and within our politics, we often promote this notion that everybody has equal access to the US healthcare system. And I know everybody in this room who's seen patients, that is not true. But I want to go a step deeper. I really want to think about what some of these things actually mean. And so the US healthcare system, while everybody, if you go to an ER, they're required by EMTALA to kind of stabilize you and do that, those low-income populations don't have the same access to the full range of the healthcare system. So if you look at this visual illustration, you can see if you have employee healthcare and you're in the high and middle income populations in the US, you basically have pretty good healthcare compared to other parts of the world. And you get this full access of primary services, radiology, all of that. And the ER is your last resort. And just think about the visuals that you have when you see your well-insured high-income patients versus your low-income patients. Whereas the low-income populations basically don't have access to all of that. Either they don't have adequate insurance or they have high deductible insurance. The thing that's most available to them often is an emergency room. And what's really important to note is that they're a lot of times in their general life, not just their health issues, they're suffering from all these other social determinants of health and basically are trying to tread water as they deal with insecure housing, economic instability, inadequate nutrition, poor education. All those social determinants of health factors are really what are compromising their access to care. And I'm sure a lot of you see this all the time where even getting patients to access care is the first challenge. And that's why, once again, I keep emphasizing the importance of addressing these social determinants of health alongside your health, especially for low income or underserved populations. If you don't address those things, they can't even reach the shore to get to the hospital, to get to the folks like you who are there to help them. Now, there have been some efforts to shift to an approach that emphasizes equity. And one of the things I often challenge people to do is when you think about government benefits, think about your own implicit bias. What are the first government benefits that you think of? I'll tell you mine. I think of TANF, the temporary assistance for needy families. I think of SNAP. I think of a lot of these government programs for low-income populations. Now, one of the surprising things to me when I got to the US was all the benefits that I had. I'm a professor at Purdue, I'm tenured, I have a pretty good job. I was surprised by all these government benefits that I got. So whether it was home mortgage interest deductions, a tax break on my electric vehicle, these were all things that I wasn't expecting and honestly didn't even really need, but I got. But when we think about government benefits in this kind of implicit bias, even the cognitive dissonance aspect of it, we never really mention those things. We only target government benefits that actually help the people who need them. And so this is one of those issues that really frustrates me is even when I do this in Indiana, once again, the only government benefits that people ever talk about are the ones that assist the poor. We don't talk about the government benefits that people like me get because for some reason, people think that I've earned them or it just doesn't make sense when I actually would not even need them. Like they don't make a difference to my daily activities. And so this approach to equity needs to incorporate some of these programs that actually try to address the social determinants of health. And things like the Affordable Care Act and Medicaid are kind of like a sailboat for a lot of these populations that are suffering. And I'm sure, once again, many of you also have noticed that the insurance that they get in the Affordable Care Act is, once again, high deductible insurance. So now if you think about that, a lot of times those high deductible insurance plans don't really cover the primary care aspects. So they have to pay sometimes upwards of $1,000 or $1,500 before their primary care insurance even kicks in. And I say all of this from experience. I work at Purdue, which is a very conservative institution, and the only thing that I have access to is high deductible insurance. And so for me, my primary care benefits don't kick in until I spend $1,200 out of pocket. And now that even disincentivizes me from getting primary care. I can't imagine what it does to somebody who has lower income and lower resources. So once again, this is a visual way of thinking of how we approach healthcare in the US. And some of these efforts to take a more equitable approach where we create benefits that actually address some of these social determinants that get people to shore and get them access to these services are where we need to keep concentrating our effort. I'll pause there and see if anybody has questions before I talk about global health and the approach that we use at AMPATH, which basically takes a lot of these things that I've talked about into consideration when we plan activities. If anybody has a quick question on the US healthcare system or any of the visuals, let me know. And this is all in one of the textbook chapters that I put together that some of you may have seen it or may see if you have colleagues that are going through med school. All right, no questions? We can save questions to the end. But now I want to change gears and talk about AMPATH, which is the academic model providing access to healthcare. And what this model really is, it's a collaboration that's directly working with the Ministry of Health of Kenya and the main academic medical center in Western Kenya. We are not an NGO. We are directly part of the Ministry of Health. So all the blessings and curses that come with that, we deal with on a daily basis. And what we basically do is we bring together all of these North American universities. You can see all the logos on here. These are all the folks that I get to work with on a daily basis in Kenya. They send faculty over periodically. I was based in Kenya full-time for about 13 years and absolutely enjoyed my time there and got to work with really talented people who are all now leading global health programs at their own institutions. And so just to give you context for the scale of AMPATH, we work across this vast catchment area of Western Kenya, which serves about 20 million people. We have now probably about 190,000, almost 200,000 people who are actively living with HIV, who are enrolled in our care, but we've expanded our mandate considerably beyond that. So we started as an HIV program, but have expanded to do population health, which means that we basically do a little bit of everything now. And so just to give you a picture for what this looks like, this is a picture of one of our group-based care sessions, which I'll talk about within the program called Big Pick. Just to give you context for this picture, this is a group that has set up microfinance activities, and we come over and provide care directly to them. And I'll talk a little bit more about the Big Pick program. So what we call it in Kenya is Big Pick Jamii. Big Pick stands for Bridging Income Generation Through Group Integrated Care, and Jamii basically means family and community. We're basically making a community-based model of care for them. And so these are the basic steps of that model. So we are proactive in going out to the community and screening people. And for those of you who are familiar with PEPFAR, which is the President's Emergency Plan for AIDS Relief, you probably recall the emphasis on screening. So what we do in this model is we take a lot of those community mobilization efforts that we have historically done with HIV and now apply them to communities. The one change that we have made based on our own experiences is that instead of focusing on health screening, what we do is we mobilize the community around things they're interested in. So that's things like microfinance, that's things like setting up agricultural cooperatives. We basically advertise that we're bringing everybody together to set up cooperatives, set up microfinance, and do all these things. And then on the side, we talk about some of the healthcare screening that we'll do. And so once we mobilize these communities, you can see a picture from what our mobilization events look like. We then organize them to form microfinance groups of 20 to 30 people. And for those of you who aren't familiar with microfinance, basically the approach we use is that people all contribute money to buy shares. You can see that group of 20 to 30 people there, and then they can take loans out against that money. And so all the money comes from the group themselves, and then people take loans out, pay interest on it, pay it back to the group, and then additional people can take out loans. But there's a lot of interest in this and a lot of demand. And so instead of requiring these people that are interested in these things to come to our facility and see us, we actually go out to the groups where they're meeting. And of course, there's also patients that we screen that are part of these groups who we can provide direct care to. And so this third step here of integrate is that it's very easy to integrate education into this. And in addition to health education, which is much easier to disseminate in a group of 30 than doing it on a one-on-one basis, which is what I'm assuming most of you guys do in your clinics, it's easier to disseminate a message to 20 to 30 people at a time. And so that's the third step, is we can integrate health education in there. We can also integrate socioeconomic opportunities into there. So we've set up agricultural cooperatives that include thousands of people now and increase the economic growth that they have. We also treat them. And so the thing that I really want to emphasize is that with the way point of care technology has kind of evolved, there's very few things that I can't do in the group that I can do in the clinic. Almost everything, 95% of the things that I need to do, I can do out in these groups. And so we bring point of care chemistries with the iStat, point of care A1Cs, blood sugars, blood pressures. We even bring echoes and ECGs out if we have people who need them, and do it right in the group. And you can see kind of what this group care triage point looks like. And if you look closely at this picture, you can see this little speck in the middle. That's me seeing patients as they go through the triage point. Now, the other thing that's important in this model, which addresses a major issue in Kenya, is that for those of you who've worked abroad, I'm sure you see time and time again that patients tell you they can't afford the services you're recommending. Since we have microfinance tied directly to our model of care, all of a sudden when they say I can't afford that A1C, and we charge the government standard rate, which is about $6 per test, what they do is basically take a loan out and pay us for the test. So now all of a sudden, instead of being providers who continue to cut corners and stop offering services because we think they can't pay, all of a sudden we start offering these services. They have the financial backing to get them. And now me as a clinician, I can start making informed decisions about what to do for their care. When prior to that, at best, we would have a point of care glucose and then largely just guess what to do with their care. Their retention increases. I would argue that the equity in their access increases because now they're getting access to all the things that the private sector gets access to and getting it in a more convenient way. So I would actually say that they get better care than the private sector in Kenya. And lastly, there's growth in demand. One of the really unique things that we've seen with this model is that other communities that hear of this model actually call us to come out and set up the model for them, which is once again a fairly novel thing, which I'm not used to seeing, where most of the time in Kenya, I'm trying to convince people to come out and address their healthcare needs. Whereas now, because we address all the social determinants of health at once, there's actually demand for this service. So just to give you a quick snapshot of some of the outcomes of our initial demonstration effort, we used to do clinic-based care, and I was one of the people that helped set up the initial diabetes clinics and hypertension clinics. And when I looked at my data, what I was really frustrated by was that very few people, if I screened them out in the community, only a third of them ever came to care. And the ones who came to care, only a third of them stayed in care. And so that's what you see in that historical control. And so the Big Pick model was basically a response to that. And we tried to figure out how to improve those metrics. And you can see that there was more than a doubling of both of those historical controls when we used the Big Pick model, where linkage rates more than doubled to 72%, retention rate went to 70%. And even with those ones who weren't theoretically retained, the only thing that happened is they didn't want to see our clinicians, but we still knew who they were in the groups. Like they still came to the groups for the microfinance, so they weren't truly lost to follow-up. They just weren't always consistently getting care. Now, as much as I'd like to think that the clinical care we were providing in groups was the main driver of all these positive outcomes that we were seeing, the real driver is down here at the bottom. So you can see this total amount shared out. And if you look at this, this is showing you the number of members and then the percent earned on savings. So basically imagine their microfinance is their own bank. And what this percent earned on savings means is, let's say over the course of a year, they saved around $100 with the group, meaning they put $100 into the group and then other people took loans out against that. At the end of the year, that $100, if you were in Janue group, that would turn into $143 because you would generate 43% interest on that because there were so many loans that were being given up. If you were in the Our Lady of Assumption group, you would leave with $161. So you can imagine what's really driving the increased uptake of all these services is the fact that there's economic growth that's tied to it. And this group of 167 people over the course of a year basically shared out almost $11,000. And this is a fairly rural, low-income group that I never would have imagined could amass that amount of money. And so just to give you a sense of the clinical outcomes, even the clinical outcomes improve. And so you can see over the course of this intervention, basically we saw a 23-point drop in systolic blood pressure, which far surpassed anything I had ever seen in the clinic-based care that I had done historically in the clinics in Kenya. And so not only did the socioeconomic side improve, but the clinical side improved. Once again, proving that those social determinants of health and the drivers of health outcomes are very closely linked together. And if you de-link them in the services you provide, you will once again be limiting the extent of the outcomes you can achieve for your patients. So what does this model of care actually look like? It's very easy to talk about this stuff, but this is what it looks like in reality. So you can see here, this is the top left picture is our clinicians providing care, point of care. So we've got a tackle box full of medications. We've got point of care labs. We've got a clinician who's talking to this patient off to the side from the group activities while the group does their microfinance. I wanted to show you what a community awareness and mobilization event looks like now. And what happened in the early days is we did not expect to see the turnout that we saw. And so we did not rent enough tents out, and now we rent out enough tents, but we actually had overflow because more people came out than we expected. Other things that we do with the program at AMPATH is, since we're a collaboration of multiple disciplines, is this vehicle you see in the left corner. That's actually a vehicle that was developed and constructed in one of the street use programs that we developed. It's called the Purdue Utility Platform Vehicle, where basically mechanical engineers designed a vehicle that could be made by just simple welding. And as long as you get the engine parts, you can basically input the engine and weld everything else together. And so this is a vehicle that's made primarily just for rural areas because of how durable it is. And so we actually sell these and use these to transport people to our events and actually transport a lot of the agricultural outputs they have. We even teach them how to do livestock by increasing access to brooders and doing training. So we've got a large effort right now to set up brooders for anybody who's interested in those economic activities. The thing that I want to keep emphasizing is that all of these things happen right alongside the clinical care. There's no de-linked effort. All of these things are done together. And so basically we wanted to prove that the aspects of this model were what were really driving the growth of this. So we did a RCT that was funded by the NIH, and I'll just show you the results, but it was a 4-arm cluster randomized trial. The 4 arms were usual care plus microfinance, and you can see the abbreviations in that allocation row of the table. GMV is group medical visit, and then the last arm is group medical visit plus microfinance. And so I just want to show you the additive benefits of these models when you look at the change in systolic blood pressure. And one of the things that actually impeded our study a bit was our usual care in some of these sites was so good that the people in usual care, because they were getting AMPATH usual care, were seeing a fairly significant drop in their systolic blood pressure. So they were dropping by 11 points, and that's what we compared everything else against. But you can see how when you add this group dynamic, so the microfinance group or the group medical visit group, it was really the group dynamic that seemed to drive this additional reduction in systolic blood pressure. And when you combine the two, group medical visit and microfinance, you saw an even greater drop in systolic blood pressure. So once again, our study, our randomized control trial, basically proved once again that this combined approach leads to additional benefits in systolic blood pressure. And that was the thing we focused on because that was the 1-year outcome, but we're still doing a lot of additional analyses to look at the socioeconomic benefits of this model. And so it's not enough to just do this as a research project, because that was never our goal. We've actively been scaling this up. And even during COVID, the trust that we had with the community allowed us to continue providing services during COVID. And we set up distance care, we set up deliveries of services, so deliveries of meds, whatever they needed, because the community actually trusted us. And so these are some of the metrics that we're seeing when we scale this up. You can see that this is data from about 1.5 years ago. We're about to do another analysis. We've diagnosed over 2,000 people. We've linked over 1,200 people. We treated all those people we've linked, and we've retained about 60% of them in our care. And now the important part is what really makes this sustainable is that we're shifting to, instead of getting them to pay fee for service, we're encouraging them to sign up for the government's national health insurance program, because then we can get reimbursed from the government and they pay their monthly premium, which is about $5 for their entire family. And we can provide whatever services they need and get reimbursed by the government. So this to me is the model that we're actually trying to promote going forward, and why it's actually sustainable is because of the government insurance program can actually sustain it. And this enrollment rate of 20.4% is much higher than the standard rate in rural areas, which is about 2 to 3%. So once again, a dramatic increase in the uptake of NHIF coverage for people who get this model of care. And so this, once again, is what some of our more recent activities are looking at is, instead of investing in more clinic infrastructure, what we've invested in is a shop. And so instead of giving all their produce and agriculture and dairy outputs to middlemen, we actually created this shop called the Kamaminet Dairy Limited, which is basically an avenue by which the group members, when they produce milk or produce some of the greens, they can actually sell them directly and keep more of the profits for themselves rather than losing it to other folks. And so this is, once again, part of our revised approach where we're emphasizing the social determinants of health and linking it directly to our service. And so this is the broader picture of what the AMPATH model looks like. This would take me about an hour to explain, but what I really want to highlight are just two main things, is that our approach is very community-centered. We're basically contextualizing everything we do around the interests of the community. The other part of that is that the outcomes we're after are no longer just the healthcare outcomes. And those outcomes are all captured in the tree you see above here. So we're trying to drive all the things you see here. So it's food security, income security, healthcare, sustainability, all those things are now our goals. And the other reality for us is that when you de-link health and wealth, you start cutting off the progress in the other one. And so we are trying to incorporate this notion that health and wealth are inexorably linked. And in all of our healthcare activities, we have considerations for wealth generation as well. And likewise, when we do wealth generation, we want to make sure that we can take care of their health. And if you're interested in looking at the full paper on this, we published a paper on this about 3 years ago called Leveraging Partnerships. And you're free to read that, and you can download the figure there as well. But this is basically the model that we use throughout our Ministry of Health sites. And we actually use this map, this large map that is basically the size of a table to actually educate people on what we're trying to do and how we're all trying to work together. And the last thing I'll really highlight is that all of this model is supported by the Ministry of Health. As you probably noticed, I'm here, not in Kenya right now. And we have a whole Kenyan team, including the Ministry of Health, that are responsible for scaling this up and continuing to manage this program. And so it's not enough to just do it in Kenya. We want to show that this works everywhere. And I was mentioning to Liz that I was actually hoping to do this lecture in person in Georgetown, but I'm currently in Georgetown, Guyana, working with the Ministry of Health to bring similar models and similar investments of health that are community-centered. We're also scaling this up in Vietnam. We're scaling this up in India, and I'll talk a little bit about that program as well. And the big thing that I want to really convey to you is that these same themes, these same approaches, we're applying to places like Indianapolis to address a lot of those life expectancy issues that I showed you on that initial slide. And so I'm sure many of you, when COVID hit, were seeing the news headlines about all the financial constraints that people were having and a lot of the issues that were happening with nutrition insecurity. So one of the things that we noticed in Indianapolis was that everybody was going to food pantries. And these were mostly the hardest to reach populations. And so what we said was similar to the Big Pick model where we bring care out to people, instead of expecting people who are already suffering hardships and financial hardships to traverse the process of getting to the hospital, why don't we go out to the food pantry and start availing COVID vaccinations there? And so through this program, we partnered with Walgreens, we partnered with the major food pantries in Indianapolis. We've basically been vaccinating people as they wait in line at the food pantry and have seen tremendous uptake of vaccines. And what we heard time and time again is that people weren't really averse to the vaccination. They just didn't have the time to do it. And to date, we've probably now vaccinated about 3,000 people through this method that all wanted to get vaccine. They just didn't have the time, money, or resources to make it to the hospitals or to the clinics where they were routinely doing that amidst their other priorities. And so just to even show you what the evidence shows about the success that American health systems can have when they incorporate nutrition and security into their healthcare system response. I just wanted to show you a quick example from Geisinger Health. For those of you who have worked at MGH or the Brigham, they also have a program that they just published about a year ago that really highlights, once again, the impact of addressing nutrition insecurity on clinical outcomes. And you can read most of these for yourself. You can see the cost is not that high. So it's about $2,400 per patient per year. And the clinical results speak for themselves. There was a 40% decrease in the risk of death or serious complications. A1C dropped an average of 2.1 points. You can see time and time again, all of these cardiovascular outcomes improved. It's basically a no-brainer, but for some reason, we're still struggling to incorporate these into our healthcare systems. But the data is out there and it's pretty clear. And so one of the things that we're doing is we're taking the lessons of the approach in Kenya and applying them directly to the two main health systems in urban Indianapolis. So that's Eskenazi Health and IU Health. For any of you who are looking or interested in physicians there, please feel free to reach out to me. We actually have a whole department committed just to addressing the social determinants of health within the health system. And so we're actively recruiting people who share the same passion. But basically, when we address nutrition insecurity, we're trying to address the whole picture. And you may have noticed that this whole acronym of Big Pick, it was chosen specifically because the goal of our program is to address the bigger picture. And so similar to what we did in Kenya, we're now applying that same approach to nutrition insecurity in Indianapolis, where we're linking the health system to educational activities for nutrition, addressing the food desert issues by including supply chains that get nutritious food to people who need it. We're creating job opportunities in nutrition in underserved communities, and we're also creating urban farms that do all this. Now, the key point I want to make about responses to nutrition insecurity is that you can't just do one piece of this puzzle. And that's often what we find as the key factor driving the failure of nutrition insecurity issues. When you look at most efforts that study nutrition insecurity in the published literature, they usually focus just on one piece. And time again, it fails. And that's why when we're doing this, we're taking this holistic model where we're trying to do all of these pieces together so it's an integrated response. And the connection to the healthcare system is going to be community health workers who are basically the dissemination arm of all nutrition activities that we want to avail to our patients, especially in these underserved communities. And you can see the tiers. We're actually customizing the nutrition support that patients get based on their needs. So the same way that you would intensify treatment based on the level of heart failure, we do the same for nutrition insecurity in this program that we've been implementing for the last 8 months now. And so, as I mentioned before, we're also expanding to other parts of the world. This is a picture of the group I work with in India, which is the Self-Employed Women's Association called SEVA. They're the largest trade union of women in the world. And I can tell you that I feel incredibly privileged to even have the opportunity to work with them. If there's any Indian women in this group who would ever want to see what a woman-run organization looks like, this is the place to go. To me, it's so informative to see how meetings work, how corporations work, when it's literally all women. They don't have any men in their organization that are members or part of their leadership. It's just really informative where there's intentional efforts to make sure every member, from the person who's the rag picker, who's part of the union, that every member gets a chance to speak. And they're actually encouraged to speak, not just given an opportunity, but trained on how to speak, trained on how to do all these things. And for me, it's really just taught me immensely valuable lessons on how women-led organizations could operate and how we should be operating in more patriarchal societies like the ones that I typically work in Kenya and also in the US. And so once again, if anybody's interested in this, we're looking to expand here as well. And if you want to be based primarily in Gujarat, where most of their activities take place, this is another opportunity to just reach out to me about. But I wanted to end there so we had a little bit of time for questions. And once again, I want to leave you with this figure. I hope that when you're seeing patients, especially in the FQHCs, that you start thinking in this domain, where if you really want to improve the outcomes of those patients, you have to expand the layers of protection they have from health injuries. And you can't do that by simply focusing on clinical care. We have to figure out a way to start better incorporating these things and make it easier to access services for a lot of these patients. And I know there's a lot of social work services in that, but it's not enough. What I'm wanting is for health systems to directly invest in setting up these services and making it an easy, accessible program for the patients who need it most. But you can see my email in the corner, and I'm hopeful that folks have questions or thoughts or perspectives that they're willing to share. But thank you again for the opportunity. It's always a pleasure to speak to you guys.